I'm Dr. Erin Kunkel, and welcome to The Middle of Everything, your podcast roadmap to thriving through perimenopause and midlife. We live in a world that insists on binaries, on black or white, right or wrong, good or bad, and we all know it's never that simple. The truth always lies somewhere in the middle of everything. And so in this podcast, I hope to cut through some of the hype and the social media nonsense and give you simple, clear, evidence-based information that you can actually take and apply to your life. Welcome back to The Middle of Everything. I'm Dr. Erin Kunkel, and today we are talking about the menopause transition and mood. So this is one of the top concerns that people bring to me in my practice. And the symptoms really run the gamut. Everything from increased irritability, anxiety, rage, all the way to hopelessness and depression, and sometimes even a suicidality. So for midlife women, these symptoms are really emerging during this time of these seismic hormonal shifts, but also at a time in our life when our demands are at their highest. We're the busiest, our attention is being pulled in a million different directions. And what's happening is we're almost losing that capacity and ability to cope. So this can be a very distressing occurrence for people going through this phase. And so I wanted to invite a specialist in this area to come on and talk to us about what exactly is going on in this time of life. So with me today is Dr. Sarah Quaratella. She is a board-certified adult psychiatrist at Hartzell and Associates with specialized expertise in women's mental health and reproductive psychiatry. She treats conditions across the reproductive lifespan, including perinatal mood and anxiety disorders, PMDD, PCOS, and mental health challenges that arise during perimenopause and menopause. Dr. Quaratella also serves as Director of Fertility Wellness Services at Intent Clinical. She has published in the Journal of Endocrinology and co-authored a nationally recognized textbook chapter on women's mental health. With a background as a Division I athlete, she brings a nuanced understanding to supporting high-performing women. I didn't know that. Welcome, Dr. Quaratella. Thanks for being here.
Yeah, thanks, Dr. Kunkel. I really appreciate you bringing me on.
Oh, my pleasure. So just to get started, I was wondering, would you just be willing to tell us a little bit about yourself and what it is about this midlife time for women that really interests you and keeps you engaged and excited doing this work?
Yeah, absolutely. So, heading into med school, I was interested in women's health. And so I was really deciding between OBGYN and psychiatry. And I realized in my OBGYN rotations, I was just more drawn to the psychological aspect of women's experiences, which really led to, yeah, pursuing reproductive psychiatry. And I feel like it's just such every hormonal transition like that women experience is an opportunity to really explore just the psychological space and the physiological space. And so I find it really fascinating to take that medical knowledge, like, that we gain in med school to try to really parse out, okay, are these symptoms more related to like a primary psychiatric or psychological condition versus really more attributable to hormone changes and just the flux that comes with that. And so I think what I've been particularly fascinated with working with women in the perimenopausal transition or menopause is just it really women are so resilient, right? Like there's so many balls like in the air, juggling so many
Mm-hmm.
things, particularly as you said, Dr. Kunkel, at this time of life. And I think it's really rewarding to be let into women's life at this time to try to differentiate, okay, or just really come up with a kind of a cause of like, where is this coming from? Like I get these questions similar to you all the time of, hey, is this perimenopause or menopause related mood changes versus a major depressive disorder or generalized anxiety disorder? And so coming at it from a psychiatric perspective is really fascinating and rewarding in that I can use that knowledge to help find the right treatment plan and refer, a lot of times I'll be referring patients to you for that
Mm-hmm.
hormonal management that I find don't need antidepressants or I'll manage them with antidepressants in my practice. So it's a long-winded way of saying it's just a really fascinating and layered time that
Yeah.
it's just wonderful to work with patients during that.
Yes. That is exactly what I have found too, and also partly why I sort of transitioned to doing the work that I do in the setting that I do is that
Mm-hmm.
there's just so much going on in a woman's life right now that makes really teasing apart what's
Hmm.
hormonal, what's an organic mood disorder, what's
Yep.
your adolescent daughter going through puberty as you're going through menopause,
Hmm.
what are your in-laws like? I don't know. Like
Right.
there's so much, and how is it? Is it just that it feels like the bottom's dropped out and we need a little bit of
Hmm.
support brought back with some hormones, or is this something more serious? So
Right.
I hope that we can hopefully today give a little bit of guidance to like what is what and what the range of treatment options might be for people.
Mhm.
Um, so sort of like you alluded to, I think that the important thing to just start with is that I don't think that there is a cycling person out there in the world who is not aware of the relationship between hormones and mood. They are
Mhm.
very inextricably linked. Now, not everybody has the privilege of experiencing perhaps a monthly shift in that. Some people don't have any changing mood symptoms with their cycle, but certainly those times of really enormous hormone fluctuations, puberty, pregnancy and postpartum, and then the menopause transition, that's when people who might not otherwise be sensitive might become more sensitive as those hormonal shifts become a little bit more extreme. So that's sort of the hormonal background. I've talked in other episodes, or will talk in other episodes about just sort of it is these crazy hormonal fluctuations that are really driving a lot of the symptoms that occur during the menopause transition. And so mood is no stranger to that. Um, just some numbers to get started with. So the SWAN study, which is the study of women's health across the nation, identified that women are 2 to 4 times more likely to experience clinical depression during the menopause transition and the early postmenopause compared with premenopausally. This risk does start to sort of attenuate and actually decrease, like the farther away you get from the final menstrual period and sort of deeper into menopause. But certainly, that time of hormonal fluctuations is a very vulnerable time for people. The greatest risk factor is actually a history of depression or some other kind of mood disorder, anxiety, etc. And that increased risk is almost twice that of somebody entering menopause with no history of clinical depression. And then on a graver note, suicidality goes up quite a bit in this time of life. There's a European study that demonstrated a sevenfold increase in suicidality during perimenopause. And then an Australian population study that looked at suicidality across all population and found that the highest risk group were women aged 45 to 49, followed by women ages 50 to 54. So this is a serious thing. This population is very uniquely vulnerable to pretty severe mood changes at times. And then there's also other factors at play. We've already been talking about just the complexity of women's life at this time, but also people aren't sleeping. People are
Mhm.
having hot flashes. People's health is changing. They might be developing chronic illness. They might be gaining weight that's limiting their exercise, which is everything is so interconnected and interrelated. So, from a hormonal perspective, that's sort of my wheelhouse. That's what I see. So, I thought we could switch to you and kind of talk about brain chemistry and like what
Yeah.
exactly is happening. How does estrogen modulate some of those pathways, and what are we
Hmm.
seeing
Hmm.
change as we go through this
Yeah,
transition?
absolutely. Yeah. And it's truly estrogen and progesterone in particular, right, that we see these huge drops, during this period are so inextricably linked with some of our major neurotransmitters. So, for example, when we think about estrogen, serotonin is really closely related to estrogen in that the estrogen increases synthesis, decreases degradation, and increases receptor density for serotonin.
Hmm.
And we all, we think of serotonin as in our SSRIs, like so our antidepressant medications, those selective serotonin reuptake inhibitors. So it's pretty clear, right? As estrogen's decreasing, our receptivity and kind of a ability to use serotonin in our bodies is going down. So we're going to see the irritability, anxiety, and some depressive symptoms potentially coming in from that. Also, estrogen modulates dopamine. And so we think of dopamine with the reward pathways, so like motivation, And I know talking with a lot of my patients that can be really affected during this time, right? And as you were saying, Dr. Kunkel, the really interesting piece is differentiating, okay, is some of this decreased motivation coming from a more depressive, because we can see that in a primary depressive disorder. Is it coming from these hormonal changes? Is it coming from the potentially the weight gain like that we can see
Mm-hmm.
in perimenopause? Is there's so many different reasons why we might be seeing these changes in motivation or even just the feeling of cognitive slowing, but dopamine is can play a role in that the receptor sensitivity in the prefrontal cortex in the brain is just decreased due to
Mm-hmm.
our lower estrogen levels. And with progesterone, so we can think of a metabolite of progesterone being allopregnanolone, which is closely linked to GABA activity. And so I tell people, so GABA is something that's in alcohol. Okay, so like that's like the primary neurotransmitter affected by that, or if like people familiar with like benzodiazepine medications, for example. And so GABA is linked to like anxiety reduction, like sleep. And so if we're decreasing our ability to use like GABA and produce GABA, then we can see those sleep changes, the irritability and anxiety. And just
Mm-hmm.
with both of these, with estrogen, again, progesterone being decreased, our thermoregulation is just in all over the place. And this is something I think
Yes.
Dr. Kunkel that you know about too. I mean, obviously you know about, but probably, like from the more purely hormonal perspective. But, we think of progesterone, like higher progesterone. It's interesting because higher progesterone, you think if some people are fertility planning, right, that like you look at basal body temperature and it's higher with higher progesterone states.
Mm-hmm.
But it's this period of time with all the changes in hormones just sends that regulatory, thermoregulatory system just like into haywire. And so we're
Yes.
seeing the night sweats, hot flashes. Yeah. And so that's just kind of a broad picture
Yes.
of like how I explain to patients, like where some of these significant changes might be coming from like the brain perspective.
Yes. Yes. There's everything talks to each other, and especially once you get the
Mm-hmm.
brain involved, then
Yes.
everything is connected. So, you know, I find that I want to start with kind of the more serious, more sort of clinically diagnosable conditions, because I think that that is really the most important thing that we need to identify when we're thinking about mood stuff. I always talk about how I want to be sure that we don't put everything in the perimenopause bucket, meaning we're
Right.
just like, that's what this is, and just pile it in
Mm-hmm.
and
Mm-hmm.
assume that hormone therapy will fix all of it.
Right.
Which seems to be what like the internet is telling us will happen. Um, so let's just start first with like clinical depression. Like, there's a big difference between clinical major depressive disorder and like low mood. And one of the
Mm-hmm.
problems with with some of the studies that we have looking at mood in this transition is that it's really hard to study it. If we're
Mm-hmm.
using like a validated questionnaire, we might be including women who are clinically depressed, but not people with low mood. So maybe we're
Right.
missing those people, or it's so the sort of prevalence might actually be a lot higher than some of the studies are suggesting. But anyway, let's just talk briefly about just depression. How do we diagnose it?
Mm-hmm.
And sort of what would the difference in your assessment be between like, oh, this looks like clinical depression and this looks like just low mood depressive
Yeah.
symptoms.
Absolutely. Yeah, no, and I really appreciate you asking that question because I feel like that's one of the biggest roles that I have. Like at this point in a patient's care, I get a lot of questions of, hey, like I have low mood, low motivation, like is this related to perimenopause or the menopausal transition, or is this like a major depressive disorder? And so the way I typically differentiate that is, through our general screening, right? So when we think of just in our, diagnostic manual, what like MDD, major depressive disorder is, we go through the following characteristics. So one being like sadness, like pervasive sadness, just low mood, just being one where we can see across the spectrum of disorders. We can see that with anxiety disorders, like perimenopause, like people just have episodes of sadness in our normal general human experience. But this is a pervasive sadness that's lasting for at least 2 weeks really at a time. So all of these questions are really within a 2 week time frame.
Hmm.
Other symptoms include anhedonia, so that means just decreased interest in activities, really not able to enjoy them the same way. You might see guilt, feelings of guilt, is ruminations about like past events, like feeling like just kind of that not um, being very like self-critical, energy, low energy being one, concentration, impaired concentration, appetite changes either more or less, or like increase or decrease appetite. Sometimes we might see psychomotor changes in a major depressive disorder, where someone is actually physically, their movements are slowed. And then, of course, we screen always for suicidality. So any passive or active thoughts of not wanting to be alive anymore. So
Mm-hmm.
for all my patients, when I'm first meeting them, I will do a depression screening. But like as you can hear and see, there's so many symptoms that will overlap with the perimenopausal transition, right? Like fatigue, the low motivation, low mood. And so when I'm parsing it out, I really, first of all, I look for severity, right? So, like, how
Mm-hmm.
impairing are these symptoms? So, in MDD or major depressive disorder, like these symptoms are causing like significant impairment. Um, in your life, and not that the symptoms are not impairing, like if this is more attributable to perimenopause or menopause symptoms, but I would expect that you're still able to kind of function in general. It's maybe harder, and we want to work on that, of course, and address that.
Mm-hmm.
But it's not so not as debilitating as I would expect in a diagnostically driven major depressive disorder.
Yeah.
Um, yeah, so that's just kind of the general overview.
Yeah, and I think that's such a it's an important distinction, and it's so important, I think, for people to understand that as physicians, we have diagnostic criteria for things
Mm-hmm.
to make a formal diagnosis. So like
Mm-hmm.
you might feel really low and not have motivation and have difficulty concentrating and sleeping and all, but you don't meet our validated
Yeah,
questionnaire, nor, but that doesn't diminish your experience. So, I think
absolutely.
that as we talk a lot about, gaslighting and all of that, I think that
Yeah,
there's a big difference between being told what you're experiencing isn't happening
right.
and
Absolutely.
and
Yes.
and then the experience of being like, I see what's happening. I don't think it's X. I think it's
Yes.
Y. And this
Yes.
is why, like, I don't think you have clinical depression. However, you seem to certainly have very low mood. And let's talk about that.
Yeah.
Like, that should stay. We
Oh,
should still
absolutely.
honor the
Yes, yes,
symptoms, you know?
yes, yes, yes. Oh, 100%. Yeah. And I think, yes, like always not just being like, oh, like you didn't meet criteria for this, so we're
Right.
not
You're
going to treat.
fine.
I think, yeah, you're fine. Like, absolutely not. Like, we need to address these symptoms. And I think it just opens, if I'm going just purely from the clinical perspective, thinking this is an MDD disorder, it's like, okay, that takes us in one treatment route in terms of like starting antidepressants, therapy, etc. Versus, okay, if I'm noticing you're experiencing all these really significant, impactful symptoms, but I'm noticing that they are more closely tied with like the menopausal transition, right? Where it's like things were going
Mm-hmm.
okay until like your period, like that your cycle was changing, like your periods are less heavy now, they're further apart. Like we're noticing these cycle changes, and that's when you started noticing, okay, I can't really sleep as well. I'm a lot more irritable. And it's then I'm thinking, okay, well, if it's more consistent with that menopausal transition, yes, you're rethinking HRT plus or minus maybe an SSRI, but just
Mm-hmm.
thinking how could we better address your symptoms? And it's interesting, like I've seen both sides, right? Where two people come in wondering, what's going on. They have the depressive symptoms, and a patient comes in, and we're noticing like their symptoms are so tied to this transition that like HRT does great and like for them,
Mm-hmm.
and in their
Right.
case they don't need like an antidepressant to help with their symptoms versus someone else who may still be going through the menopausal transition, but layered on top of that is a major depressive disorder, potentially based on that vulnerability, as you discussed, like if they
Mm-hmm.
had prior depressive episodes. And so I think that's what makes it so interesting, right? Like it's so
Yes.
nuanced, and it's like very, and it's just always wanting, for me, a priority is always to be adaptable, right? Like if I off the bat, I'm thinking, okay, like based on our initial conversation, this is seeming more consistent with MDD, major depressive disorder, not just being like, that's not being dogmatic about it and being like, well, that's it, right? Of course, like integrating new information. working with, physicians like yourself, like who can give like the perspective from the GYN side of things. So it's,
Hmm.
that collaborative care and just continuing to reevaluate, I think is so important in
Yeah.
really creating a tailored, personalized plan.
Right. And also, like we've said already several times, is that everything is connected. And so, especially in
Hmm.
the menopause transition, when there are other things going on that might be impacting mood,
Right.
deprivation, hot flashes, all of those, or chronic disease progression, sometimes, if we get somebody sleeping because we treat the night
Yes.
sweats that are waking them up at night, then their mood
Right.
improves. And so,
Yes.
we can kind
Yes.
of like there's a lot of thinking that thinks that the role that hormone therapy seems to play in the improvement of mood symptoms actually is vis-a-vis the improvement in
Yeah,
other things.
absolutely. Hmm.
And so, I certainly have seen people who only have mood symptoms. They don't have hot flashes. They don't have sleep disruption, and they do get
Yeah.
better with hormone therapy. And those are the women,
Yeah, for
like I
sure.
said at the beginning, where it just feels like the bottom drops out.
Yep.
They're just like, I was standing on solid ground and now I'm not, and I don't know what happened.
Hmm. Hmm. Hmm.
Um,
Hmm.
so, a lot of the literature talks a lot more about depression, but I see so
Right.
much anxiety in my
Yeah.
practice.
Hmm.
So, can you talk a
Hmm.
little bit about anxiety and what you see in this transition?
Absolutely. Yeah. So when we're thinking about anxiety, there's multiple anxiety disorders, but like the one that we probably think of most commonly is generalized anxiety disorder. And so for GAD, I would be screening for, anxiety that's persistent, difficult to kind of take your mind off of it, a lot of rumination, oftentimes associated with physical symptoms in terms of like, raising your shoulders, like tightness in your body, difficulty controlling the worry in general, and just kind of what I was saying with refocusing. And
Hmm.
typically, not always, but like with GAD, if I'm working with someone in the kind of age range of the menopausal transition, this is typically not something that would appear right out of the blue, right? Like a lot of this is from physiological, but also like situational, just based on how like you were growing up and kind of there's so much going on with generalized anxiety disorder where it would be I would it's not impossible but uncommon I think to just like if someone comes to me in their early 50s and it develops just a de novo generalized anxiety
Yes.
disorder.
Right.
Of course like there's like a post traumatic stress disorder, right? So if there's like a trauma that we identify, we'll see some like sequela of that, including like
Hmm.
hypervigilance, so being really on edge. We can see nightmares with that, kind of a low perception, like a negative perception of self. Flashback. Like there's other symptoms associated with that. And while not formally characterized, as an anxiety disorder in our diagnostic manual, OCD is like another one of our big,
Hmm.
considered generally by the public, kind of a disorder of anxiety. And so
Yeah.
that would be things like intrusive thoughts that you can't control our thoughts, right? So there's thoughts coming in that are really distressing, and I describe to patients, it's almost like the spam filter in your brain is broken, and that instead of
Yes.
dismissing that thought as if you know you like that's a weird thought and kind of move on with your day, it gets really
It
stuck.
latched. Yeah.
um, it latches on, and then it really starts a cascade of repetitive behaviors aimed at neutralizing that. So like in media, right? Like we see the very common one of like cleaning, right? So like if someone is deeply afraid, they have an intrusive thought of, eating something with germs and getting sick, then we'll see potentially as a compulsion someone like having lots of repetitive cleaning behaviors. Anyway,
Yeah.
so those are kind of the main more common disorders that I would associate with like someone complaining of anxiety. And so when I'm talking with a patient, trying to tease out, because like we talked about from the purely neurochemical standpoint, like as we're affecting serotonin, dopamine, and GABA, that's all like though like it's all going to kind of lead to this potentially increased anxiety, and also as we're making it as we're decreasing the brain's ability to like utilize dopamine, that motivation and kind of cognitive clarity potentially decreasing,
Yes.
that can cause anxiety on its own, right? If
Hmm.
it's not and so I think this is something I talk with my patients a lot about, is that is there anxiety related to just forgetting things, right? Like forgetting things that you were doing due to this brain fog. And I think we'll talk about it later, like in the
Yeah.
podcast, but this comes up a lot, like beyond just the anxiety disorders, but the attention piece where it's like,
Mm-hmm.
do I have ADHD now? Like, because I'm not
Mm-hmm.
remembering things, and that can lead to anxiety. And so, there's so much to tease out in terms, and I'm not sure if that really answers the question, but, in terms of like how long the anxiety has been going, if it's tied to a particular stressor, or if it's feeling just out of the blue. I mean, I've had some patients who just feel physiologically anxious, like just like
Yeah.
their body feels anxious, but they can't tie it to a
Mm-hmm.
particular stressor. And to that, to me, is okay. Like that's sounding more like a hormonal transition because it's just
Mm-hmm.
your brain chemicals are being altered, as opposed to someone who tells me, okay, like the example you mentioned with like their adolescent daughter, where yes, it still might be related to a hormonal
Mm-hmm.
transition, but also like there might be like a response to just a stressor related to that.
Right.
And so yeah, it can get very sticky, which makes it very interesting, but yeah, trying to parse out what's actually going on.
Yeah. Yeah. I loved what you were saying. This might be a good segue into just talking briefly about cognitive behavioral therapy, because
Yeah.
especially in this time of life, I mean, there's so much great evidence for the use of CBT for hot flashes, for insomnia, for
Mm-hmm.
weight loss, for
Mm-hmm.
so many different things that are very
Mm-hmm.
common concerns of this transition. But CBT in general is just so awesome. And
Yeah,
you already
it
sort of
is.
touched on the fact that like thoughts are thoughts. And that,
Mm-hmm.
the way that I explain CBT to people is just that CBT is going to help you change how you relate to them. Right.
Yes.
So it's like something happens, you have a thought, and the work is in that space. Like, how can I
Mm-hmm.
change the
Mm-hmm.
thoughts that I might be having? So if
Right.
you wouldn't mind just talking a little bit about CBT and the role that that plays, because I always worry that people are going to be like, oh, see, I knew that she thought it's all in my head or whatever.
Yeah.
It's like
Yeah.
that's not what we're saying. That's not what this
Absolutely.
recommendation is about.
A
Um,
hundred percent.
so what do
Mm-hmm.
you have
Mm-hmm.
to say on that front?
Yeah, no, absolutely. And there's so much evidence supporting the efficacy of CBT in everything, that you mentioned. And exactly, I always, it's talking about like CBT is definitely, I think, less. I think people could consider it less of like a potential immediate fix, even though we know for antidepressants those aren't immediate either. And HRT can take time too, but it's so effective. And so the way I describe it to patients is, yeah, CBT is really focusing on the relationship between thoughts, feelings, and behaviors. So sometimes we even draw a triangle to
Mm-hmm.
describe that. And so thinking about thoughts, I think we don't I think very like metaphysically about thoughts, right? Like they're
Mm-hmm.
just happening or having like them all the time, but
Yeah.
they're not something that we can control, which seems odd, but they're just that's the crazy way our brain works. Like thoughts are coming in and out of our head all the time.
Yeah.
Um, and so we can't control that. Also, like in the, like immediate sense, we're not really typically able to a lot of times even control our emotional response to a thought. That's something that like can change over time, like with CBT, with medications, things like that. But a lot of times we have a thought and there can just be a sudden emotional response related to that thought. But where we do have more of that control and we work on gaining more of the awareness of that control is how we react to the thought and the feeling, right? So if I give an example for like a patient, for example, who is struggling to sleep. So like CBT for insomnia is really well validated for
Mm-hmm.
sleep disturbances. And so the thought might be, I'm never going back to sleep. Like I'm awake all night. The emotion that might come from that might be like really high anxiety. Like oh no, like if I don't sleep tonight, I'm not going to do well at work tomorrow. I'm going to, sleep through my alarm, XYZ. And then the behavior, it can really vary from there, right? Like the behavior might be, I'm going to scroll on my phone because like I can't sleep and I'm kind of giving up whatever on that.
Yeah.
I'm too frustrated. Um, and that's where we really try to evaluate, yeah, how to recontextualize that thought. So maybe instead of saying I'm never going back to sleep, it could be just I'm not sleeping right now. Like, how can I, like that? Yes, you can validate, like, that's stressful. I wish I was sleeping right now.
Mm-hmm.
But what else? Like, is there something I can do? Like, and also, like, is there something I can do? For example, like sleep hygiene, like maybe you leave your room for a half hour, like, and read a book, like going off technology. And not to say like, okay, this is, I think sometimes people might think like, so you're just telling me that it feels very invalidating. You're saying I'm not doing it right. Like
Right.
I just like, and that's not the case at all. It's just like
Yeah.
our brain seeks as an adaptive mechanism, like seeks comfort, right? And sometimes like the way that we seek comfort, like isn't helping us as much. Like it's no longer adapted. And so that's
Mm-hmm.
where we work on developing these skills that can help make it a little bit easier. And so just kind of reframing it. Maybe it's, telling yourself, I can just rest right now, or like I've gotten through hard days before when I haven't slept. Um,
Mm-hmm.
and this is like not to say that we're going to do this in the absence of like medication or HRT or anything like that. We just, I think this is a very useful. I mean, there's a lot of evidence to support that for treating lots of conditions that CBT or therapy in general with medications can be like a really excellent approach. And so, yeah, this is a long-winded way of saying like this is just trying to take the variables that we may be able to control,
Mm-hmm.
to have you feel a sense of autonomy, that like this is like your life isn't just happening
To you.
without it to you, right?
Yeah.
And just empowering you to be to trying to feel like, okay, no, I can do something like about this. And yeah, and
Yeah.
it takes time, but can be really effective.
Absolutely. Yeah, I love CBT. I think that it is such a powerful tool, and especially when it's used in concert with other things if
Right.
needed, because I think that sometimes the idea of doing that work with a super cluttered desk is like
Yes.
really hard, right?
Yes, yes.
And so sometimes just like clearing the decks so that you can actually do the work in CBT with a medication is very helpful. Um, you already touched on it, so why don't we go ahead and seize this,
Yeah,
the cognitive changes.
right.
So, I've been hearing so many people come to me saying, I feel like I have ADHD all of a sudden. I actually went for neuropsych testing and I don't, but like I feel like I do.
Mm-hmm.
Or
Mm-hmm.
what is happening? I mean, brain fog is ubiquitous.
Yeah.
And, I think that brain fog is something that we know it when we see it, but it's hard to
Mm-hmm.
describe.
Mm-hmm.
So how would you describe brain fog? Is that what we mean by ADHD? Like, is it this difficult? Is it our attention being so fragmented? Like, what exactly is going on with that?
Yeah, it's a great question. And there have been so many more, yeah, questions about ADHD, I think, in the age of all of our technology, and it just how much does that play a role, right? So when the way our current understanding is of diagnosing ADHD, so it's categorized as actually a neurodevelopmental disorder that is diagnosed typically it's not always diagnosed right like in childhood, but we see patterns of like difficulties with attention, impulsivity, um, in childhood, and it's the symptoms, like the attention kind of related symptoms are not variable, like based on changes in stimuli, right? So like maybe with some like, okay, a class that's interesting versus not, but for example, like getting more sleep is not necessarily in ADHD, how we see it currently, is not going to affect your ability to pay attention in class, for example.
Hmm.
And the reason I say that is the difference between, like brain fog, the way we currently conceptualize it is that it is usually there's an underlying etiology that we can address. Typically, it's not something that's lasted your whole entire life, or most of your life. It's something that can be more episodic, more linked to a stressor. So for example, like if someone hasn't gotten sleep for a couple of nights, like we might see brain fog. But if they get the sleep, like if that's the cause and they get the sleep, we'll see a like reemergence of like their typical cognitive functioning.
Hmm.
Where this is difficult, right, is in hormonal changes that affect our attention. There might be a long time where if someone like doesn't get treatment for that, it does feel they're like, this does feel like it's been going on for my whole life, like, or forever,
Yeah,
just because we're not actually like addressing the cause of it. And it's really can be so debilitating. Again, like as we talked about, like not, I think there is this idea that like, okay, if it's not ADHD or not like major depressive disorder, it's not real, it's not respected in the
exactly.
medical community, and that's not, I mean, and I try to emphasize to all my patients that's not the case at all. Like I think this is very very real. It's just doesn't fit into that one box that we often use just for a lot of times billing, but also just for kind of creating a kind of like bucket of like a diagnostic formulation. And so these symptoms are very real. It just changes our approach. And like that's the value of it. It's like I don't want to give someone a medication that's not going to help when the root of their symptoms is like a depletion of these hormones, right? And so
Yeah.
but it's a hard conversation because I think it can feel very invalidating that like,
Mm-hmm.
and I want to make sure like I don't think that you're not dealing with like this brain fog. This is very real. And for a lot of really, high performing, high achieving women, like in the workplace, like just in their social relationships, it can be really hard and really frustrating. And so I want to make sure we address it, even if it's not with the ways we might treat ADHD.
Right.
Yeah.
Do you typically see hormone therapy help with ADHD symptoms if it's hormonally mediated?
I do, yeah. I
Yeah.
think I do, yeah. I had one patient come in, yeah, with just low mood, brain fog, not as much anxiety, poor sleep, attention difficulties, like wondering if she had
Mm-hmm.
ADHD. And so really the question was, is this depression and ADHD? Like, they're
Yeah.
like, those were kind of like the main questions of the appointment. And for her, like didn't meet criteria for ADHD, didn't meet criteria for depression or major depressive disorder. And but was still having these pervasive symptoms. And again, this was like in her, she was maybe 52, was noticing, wasn't, was in the perimenopause, this kind of transitional period where, yeah, she was noticing that change in the frequency, duration, amount of like kind of her periods. And so she was someone where I said, hey, I actually don't think we need to treat you with an antidepressant or a psychiatric, primarily psychiatric, traditionally considered psychiatric medication right now. And we got her on HRT and her symptoms improved like across the board. Like
Yeah.
all of these symptoms improved, right? And
Yeah.
so, which I think it's so important that psychiatrists, like know, like, like who are treating
Mm-hmm.
women, like in this like time
Mm-hmm.
period actually know this, right? Because I think you could, if you didn't have the awareness of how much like these hormonal shifts affect neurotransmitters and behavior, emotions, like sleep,
Yeah.
all these things, I think easily someone could say, okay, if you're not putting the pieces together, being like, okay, there's some depressive symptoms, some sleep issues, some attention issues. Like, let me just put on like, an SNRI, so like medication for depression that can give someone a little bit of energy. So that's like
Mm-hmm.
serotonin, norepinephrine reuptake inhibitor, and put on a sleep med at night. Okay, so like helping with
Yeah.
sleep. So like let's see if that kind of like helps out with things, and maybe it would, but I do think to some extent like that's missing the forest through the trees, and not
Mm-hmm.
actually getting to the heart of like what is driving this constellation of
Right. Like
symptoms.
what's the root cause, right?
Right, exactly.
Yeah.
Yeah, right.
Yeah, so I mean, this might be a good time to talk about hormone therapy and its role in the
Yeah.
treatment of these disorders. So, it does seem to help just in the things that I've read that hormone therapy really is better in those women with depressive symptoms as opposed to
Mm-hmm.
like an MDD or like a clinical
Right.
depression.
Right.
Those women probably would benefit more from an SSRI, an SNRI, or some
Mm-hmm.
other
Mm-hmm.
medication
Mm-hmm.
directly targeting that. So that's why that's an important branch point
Yeah.
in the sort of the
Right.
diagnostics of it. And then the second thing that I just like to mention, especially for women who are sort of early in their perimenopause
Mm-hmm.
transition, maybe in the
Mm-hmm.
later reproductive stage, early perimenopause,
Mm-hmm.
is that sometimes the perception of these changes feels like PMS on steroids. Right.
Mm-hmm.
So, like, like we talked about at the very beginning, hormones and mood are, sometimes people are just more vulnerable to sort of that interplay of
Right.
hormones as they shift. And as those hormone shifts become a little bit more amplified, people might start feeling it for the first time. So, it's
Mm-hmm.
really like an emergence of PMDD, which is premenstrual
Mm-hmm.
dysphoric disorder.
Mm-hmm.
Um, that's sort of in the same time period. And so it's a little bit like six in one, half dozen in the other. Like, what difference does it really make what we call it, if we
Right.
call it PMDD or we call it early perimenopause?
Mm-hmm.
But in the same way that we know that like a birth control pill can be really helpful for PMDD in like a 25-year-old, the same
Right.
is true for a 45-year-old who might be
Mm-hmm. Mm-hmm.
experiencing this for the first time. If what's driving the symptoms are these wild fluctuations,
Right.
sometimes just like going into a flat line or like
Hmm.
getting off the roller coaster, like
Yeah.
is the answer. So
Hmm.
sometimes, sometimes you'll see some bickering like on social media of like, it's not PMDD, it's perimenopause, and no, it's PMDD. It's like this back and forth. I don't think it really matters because at the end of the day, I'm most interested in treating the person in front of me.
Right, right.
Um, but certainly that is sort of a piece of the puzzle, and sometimes a birth control pill can be helpful for that. Um, but there's lots of studies that do show, some good evidence around using hormone therapy for
Yeah.
depressive symptoms, for
Hmm.
clinical depression.
Hmm.
One study really showed a lot of benefit with oral estrogen. Another one showed
Hmm.
benefit with transdermal. We tend to sort of lean more transdermal nowadays.
Hmm.
Um, doesn't seem to be effective as like a prevention. So I don't know what your thoughts on this are, whether if somebody is coming into the menopause transition having had really severe postpartum depression or
Hmm.
prior episodes of major depressive disorder earlier in their life, or their puberty was a hot mess or something like that. If
Hmm.
there's any benefit to sort of like starting hormone therapy out of the gate, doesn't look like there's much evidence to support that, but I don't know if you have a thought about it preventatively.
Yeah, no, I would agree with you on that. Just like based on the research that we have available to us now, I'd say that I have seen patients who are really, yeah, in that I'd say late reproductive stage,
Mm-hmm.
and really haven't seen that much like change, like not like in terms of like vasomotor symptoms or like changes in their cycle, and but are reporting some of these symptoms, and I think that's an area I think that we will continue as so much more hopefully evidence and like in research comes out in this area, this we will learn more. But I would say in my experience, and maybe I'll just continue to learn more over time, but I wouldn't, I
Right.
don't really prescribe it at that point. At that point I think I'm focusing more on, okay, like if maybe we're not seeing kind of overtly like at this point the hormonal changes, like do we address it more of like a PMDD or something like
Yeah.
that, or which is so interesting in itself. Because in PMDD we do typically, a lot of times we'll do the luteal phase dosing, and so like how do you
Mm-hmm.
manage that when the hormones are changing so much?
Yes.
But yeah,
Yeah. And while we're in the luteal phase,
yeah.
sometimes people do have that progesterone intolerance where instead of progesterone
Mm-hmm.
having that GABAergic response, I can never say
Yeah,
GABAergic, and being
yeah.
being calming and and restful. Some people have the total opposite where
Yeah.
progesterone, even when we give them progesterone as part
Mm-hmm.
of hormone therapy,
Mm-hmm.
they get like ragey and
Yeah.
agitated and activated. That I wouldn't say that that's a huge percentage of people that I see, but that is certainly a consideration to sometimes hold in our
Mm-hmm.
awareness, right? What would you say with that progesterone intolerance?
Yeah, yeah. I honestly, I haven't seen that as much. I am sure, like with the amount of women you're treating with HRT, you've seen it more than I have.
Hmm.
But I think, I do warn patients about that, right? Where it's like, okay, we're particularly like if the distress is so high, like so sometimes if we're doing HRT and like antidepressant therapy, because I know we've talked a lot about, or like I've talked a lot about kind of choosing one or the other, but there will be cases, right, that I will use both together where I think, okay, I think
Hmm.
there's a
For sure.
large like component of this that is related to this hormonal transition, but and it's causing so much distress that it's actually concurrently like meeting criteria for a primary psychiatric disorder. And so like we're
Hmm.
also going to treat it with like an SSRI, SNRI medication. And so I would say, yeah, I always warn my patients. I think I do that. Yeah, we might potentially go the other way with something like progesterone, but again, not
Hmm.
as I haven't seen it as much in my personal experience. But
Yeah.
always just want everyone to be aware that anytime if there is that sensitivity to hormones in general, particularly if there's a past of like PMDD, something like that, like then I'm like, okay, we just want to be cautious.
Yes, absolutely. Yeah. I don't, and to be clear, I don't see it a ton, but every
Yeah.
once in a while you get people who are like, I don't know, I started that pill you gave me that I'm supposed to take at bedtime and it makes me insane. That's like, okay, we'll
You're like,
we'll
okay,
back
let's
off
not do
of that.
that. Yeah.
So we're nearing the end of our time. So just sort of wrapping up, I want to just touch a little bit on sort of more of I don't know, the word poetic is coming to mind. I don't know what's exactly the right word, but we've talked about this sort of perception that people have as they go through this transition of like, I'm used to having like 20 balls in the air and like
Hmm.
I'm dropping them and I don't like that and I need them back. And
Hmm.
and it's like, okay, there are ways that we can help support you to maybe get those balls back in the air. But I think an interesting question to maybe start to explore in midlife is, are we supposed to have 20 balls in the air? Like, are
Hmm.
human beings supposed to do that? And I think certainly this is a very gendered comment, but certainly women seem to bear more of that,
Hmm.
sort of the mental load, just so much of the extra stuff of our lives. And so I think that the idea of like, when you're starting to experience this change in focus and attention and capacity and resilience, what what can you set down? Like, what can
Hmm.
we let go of? And obviously, most people don't have the luxury of like quitting their job or,
Right.
taking a sabbatical and going to Portugal for 6 months or whatever. Though that sounds lovely.
Right.
We kind of have to find those ways in our day-to-day life to do that. So I like to talk to people about like finding like the pressure valves, like the pressure
Yeah.
release valves, like on your slow cooker or your pressure
Hmm.
cooker, where it's like pss, like crazy pressure release, and just find those throughout the day.
Hmm.
So like, what kind of tools do you recommend to people to kind of like find those little moments throughout the day where you kind of are releasing that pressure or you're calming your nervous system or however,
Yeah.
like whatever it is that we can kind of infuse our life in a sustainable way with a little bit more calm and peace?
Yeah, absolutely. No, I think that's an excellent point. And a couple thoughts come to mind. I'd say one is a lot of it comes down to kind of the basics, right? Where I want people seeing the sunlight. I want them to go outside. I want them to do some exercise, if that's like light walking, if it's running, if it's whatever it is. And part of that is, yes, the physical benefits, right? Of like getting the vitamin D from the sun and just all of like the cardiovascular and mental health, et cetera,
Yeah.
benefits of exercise. But I think it's another way of that I really encourage my patients to prioritize them like themselves, right? And I think you mentioned that women, as a generalization, but we see a lot like take on so much and can have this societally projected guilt of like taking time for themselves. And I think during this transition, during any point of life, but especially during this transition that's such a big adjustment, I think it's really important for women to show themselves that like they are making time like for their well-being and their health. And for me, what that ties into a lot is self-compassion. I talk to a lot of my patients
Mm,
about this. A lot of women, again, as a generalization, but are very self-critical, particularly as their body is changing, right? They
yeah.
are like, I want to perform at the same level that I always have, and really trying to just emphasize like it's okay. Like my body is adjusting, and that's okay. And if that's hard for like, and if that's feeling hard, that's it's normal. Like it's normal for it to feel hard, and not to be invalidating, but just to not. A lot of people say it shouldn't. I shouldn't be this upset about it, or it shouldn't affect me this much. It's okay. This is a
Yeah.
challenging time, like and like to give yourself that grace. I know it sounds like a cliche, but like there just to take some of that self critique and just be like, this is part of my body's process. Like I'm just going to experiment with what feels good for me right now in this stage of life and whatever that looks like. And
Hmm.
so those basics of like social connection, like maintaining connection with others, being outside, exercising, and just being kind to yourself, are just, they sound very like simple in a lot of ways, but are some things that I emphasize as, not being so critical of these adjustments and just trying to, yeah, trying your best to be like, it's okay that I'm maybe not, not
Hmm.
where I want to be, but I can have help. I can reach out for help and like to you, to me, to all these different people to like help get you feeling good at this point in life, whatever that
Right.
means for you. If that means like,
Right.
yes, like now being CEO of like a Fortune 500 company, or if it means like pivoting in your workplace, if it, whatever it means, like, but
Yes.
just, yeah, you're not alone. And there are ways to support you.
Yeah. Yeah. What are things that you do? You're busy.
Yes, yes. I am. No, I try to practice what I preach. I really do. I
Yeah.
being in Colorado, I have the benefit of it being sunny, like some crazy amount of time, like 300 and something days a year. So I'm always getting outside. I love walking. I just recently, within the last year, started doing Pilates for
Hmm.
like that, like low, like that strength training. You know, it's good for your bones, everything, and I love it.
Yeah.
As you like in my bio, like I ran track and cross country. Like Division 1 at Yale in college. So I come from like a very exercise heavy background. I
Yeah.
don't do that anymore, but like I'll run occasionally.
Yeah.
Yeah, I love like getting coffee with friends. Like I try to do the things to the best of my ability that I can.
Yeah.
What
Yeah.
about you? What do you do?
Well, yeah, same thing. I try to practice what I preach. Sometimes it's easier.
Hmm.
I did just get a dog, and I have to
Oh,
say, we rescued a dog. She's almost 2, so she's
oh,
not a puppy, which was critical, I think,
yes,
in the assimilation of this dog into our
yes.
house. Um, but I have been amazed at like how soulful this dog is
Hmm.
and how regulating she is.
Yes,
And
yes.
I shared it with another colleague who's a social worker, and she was like,
Hmm.
"There's a study, and I'm gonna not get it
Yes,
totally correct, but like that petting an
yes.
animal for 10 to
Hmm.
20 minutes a day is
Hmm.
equal to meditating for 30 minutes a
Yes.
day."
I know.
Amazing. And
Yeah,
I feel
right?
that, and like the how often I just sit on my couch phoneless petting
Yeah,
her. I'm just
yeah.
like, I nothing else, not even my child will like will motivate me to sit totally calmly.
Right,
Like,
right.
I don't know, there's just something about this dog. So that's been great. And then obviously she's been getting us out into nature and walking
Yeah.
more, and that really has also been just very grounding. I sleep better because I'm
Hmm.
moving
Hmm.
more,
Yep.
reading, snuggling with my daughter and all of that. And then things that I
Yeah.
find are actually really like helpful. And I was just talking to my husband about how I think it's a key part of adulting, which is remembering my future self. So like
Mm, hmm.
remembering that like even though all I want to do is go to bed right now, I
Hmm.
know that if I clean my daughter's lunchbox so it's dry in the morning, I'll be happier. And
Yeah.
I find like sort of keeping that in perspective of like how can I continue to every day like take care of myself like tomorrow,
Yeah.
right? So that like my life's a little bit easier. I feel like
I
those are
love that.
things.
I
Those
like
are
I feel like I want to do that. I feel like I have almost the opposite mentality where I say like future Sarah's problem and but that's like it's like where I'm just like and then I'll be like oof like if I don't even know what it is, do something in the kitchen. So I feel like I need to adopt like future Sarah will be happy if you do
Yeah, it
this.
doesn't apply to everything. My kitchen is
Yeah,
pretty
of
much
course.
always a mess.
Yeah.
But Sarah, this was wonderful. Thank you so much for
Yeah,
joining me
thank you,
today.
Erin. Of
And yeah, and
course.
I think that this conversation is just so helpful because again, like we hear you, or if you feel like your
Yes,
provider doesn't hear
yes,
you, find someone who does. And
yes.
just because you might not fit neatly into a box doesn't
Right.
mean that your symptoms aren't real, that they're not
Mm-hmm.
happening. It just means we might need to take a different approach and get
Yeah.
creative in how we think
Yeah.
and sort of think outside the box. So I
Mm-hmm.
think that this conversation was hopefully very validating. And it was a pleasure.
Awesome. Thanks, Erin.
All right. Thank you. And thanks everybody for listening. And if you're interested and want to be kept up to date on future episodes, then you can hit subscribe. Bye.